Hello and welcome to Checking the Vitals, a podcast powered by SpecialtyCare. I'm Todd Schlosser, and today our guest is Dr. Schwoerer, who was a bariatric specialist in Bridgeton, Missouri. In this conversation, we discussed how working at a lab in college helped her decide to practice medicine. She also shares why she chose to focus on minimally invasive surgeries and how robotic technology is changing the way these surgeries are done. Enjoy the conversation. I'd like to start off the podcast by asking, sort of what was it that led you to want to work in a career in healthcare?
Specifically to bariatric surgery, that's a little more tricky. Medicine in general.
Yeah, let's do that.
I actually started off as a biomedical engineer.
Oh.
So I am very, math and science oriented.
Sure.
I love hard numbers, which is funny because surgery is nothing like that sort of. But I love, you can figure it out. You don't need to memorize everything. You can figure it out and it works. And so I was in biomedical engineering. I went to the University of Wisconsin-Madison, and I was actually working in a lab. And I was working in a lab growing organs at the time. So
Oh,
this
wow.
was a while back. Yeah, I was trying to grow cardiomyocytes, which are heart cells. So we were growing heart cells, and, what you don't realize is when you work in a lab, you actually have to feed the cells, come in on the weekends, on the nights, and feed them, make sure they're alive. And so I was there probably really late on a Saturday, and all of a sudden these heart cells start pulsating. And I'm like, oh my God, I'm going crazy. But they're not, because that's what heart cells do. They beat.
Sure.
So we're growing these organs, they're beating. I think I'm going crazy because it's late Saturday night. I'm in a lab by myself. And I was like, I just kept on thinking about, I love helping people and developing new techniques, and I miss the human interaction. And so I really thought that medicine would be a good bridge where I can apply everything I learned through science, math, engineering, and apply it to actually treating patients and having that human interaction. So I think that was kind of a pivotal moment when I decided healthcare.
I've talked to a lot of people who actually ended up being perfusionists or neurophysiologists or things like that. And they had lab jobs at the beginning. And they're like, I'm too much of a people person to do this. And it sounds like you had that sort of epiphany alone on a Saturday night while looking at small beating hearts. And that sounds like the beginning of a horror movie to me. So I definitely understand the want to switch out of that. Although I will say lab work is for certain types of people and they do it well, and we appreciate all the work that they do. But let me ask this, because you were already working in a lab when you had the epiphany or the thought of, I want to be a surgeon. So for those who don't go straight from their regular collegiate life, right, undergrad, and then go right into med school, what did your path look like?
Yeah, so I had my lab job while I was a college student at Madison.
Oh, forgive me. I thought you had done that for a few years after college.
No,
okay, that makes more sense.
That was part of college, correct.
Okay.
My senior year was more of, you had a lot of co-ops and individual courses you pick for yourself as an engineer to develop a thesis theory, and that was one working in the lab doing that. So that's where I started that. So I went I did the straight through path,
Okay.
Just plowed right through it, went straight from high school to college to med school to residency to fellowship, and then now working. So it's been a long tunnel.
Yeah, no, absolutely. And obviously, having done it and being on the other side, you can look back on it, glad you did it. But while you're in it, I'd imagine it's harder to stay motivated throughout those times.
It is. What's nice is about it, a lot of these segments of your life are broken up for you. So you have kind of a defined end. So, med school is about 4 years, so you have a kind of an end. Residency, depending on what you go into, has a hopefully defined period of time.
Yeah.
I actually decided to prolong my residency. I did a year of research up at the Cleveland Clinic.
Oh, yeah.
So I did a year of research studying actually bariatric and minimally invasive surgery. So that kind of also helped me define my career, and then finish residency and then fellowship. So at least you have kind of defined hurdles to jump through. So
Sure.
Little glimpses of lights through the tunnel.
Little milestones, if you will.
Oh, for sure.
Absolutely. So can I ask, so you went to med school, obviously you finished med school. Was it in med school you decided that bariatric and minimally invasive surgery was your path? When did you make that decision?
So I knew that surgery was for me when I was a med student. So that's where I decided surgery.
Right. But when you go to residency, you don't have to pick what lane, right? Is that correct?
Certain lanes you have to pick. So
Okay.
when you match into a residency program, you have to know, are you going to be doing, sometimes plastics? Are you doing orthopedic surgery,
Okay.
urology? But if you go into general surgery, you can still branch off from there into the other specialties.
Okay. So what path did you take? Did you go
I took general.
general?
Yep. I went general surgery.
Okay. So when did you decide that bariatric and minimally invasive was where you wanted to head?
That was probably when I did my research year.
Oh, okay.
So I did my research year after my second year of residency. So I stepped out for a year.
Okay. And that's a common thing, right? During residency, you step out for a research year and then you can just plug back in, correct?
Correct. Yeah. And it depends on which program you go to. Some programs are more amenable to research. Others are just, getting you through 5 years. So it really depends. I
Yeah.
think some of the more competitive career choices, some of the more competitive fellowships, you really have to have some of that, other experience or other research in there. You want to have a better, background in what you're doing. Kind of like getting into med school or getting into college.
Right.
Even if you're a straight A student and you want to go to college, you have to have those extracurriculars to make you more competitive. And so
Right.
the research really helps. I presented at a couple national conferences. I had papers published. So really kind of puts you out there.
Yeah, no, that makes complete sense. I mean, when you're even applying for college, they want to see that you're a well-rounded student. So I'd imagine it's very similar, especially when you're, and I hate to use this cliche, but sort of continuing your education into a fellowship.
Mm-hmm.
They're going to be looking for, is this person going to be a pillar in the community? Sort of. It is a much smaller community, though, as there aren't, hundreds of thousands of surgeons, but I'd imagine they're wanting to look for the best candidate to fill that fellowship because there are only a limited number of spots
Correct.
in each
Yep.
one.
Correct. It is getting more and more competitive. And I think same thing with, out of high school to college, people don't know exactly what, you don't know you're going to be a surgeon. I mean, some people do, but I didn't know I was going to be a surgeon when I was 10,
Right.
You kind of make up your mind, even though I think someone asked me a long time ago when I was a child, and they're like, oh yeah, I want to be a surgeon, and just kind of spouting things off. But you
Sure.
don't really know what you want to do now. So it takes a little longer to figure out what you want to do. So I think more and more people want to do a fellowship to kind of hone in and define their skills. And in order to get there, you have to be, like you said, well-rounded and kind of well-versed in, research, academics, everything.
Sure. Now, let me ask, when you went into your fellowship, was that to learn a specific technique or, a certain type of procedure, or was that more of a general fellowship for bariatric surgery?
So it was specifically for bariatric surgery. So
Okay.
I actually, so there's different types of fellowships. So there, acute care fellowships, trauma fellowships, vascular fellowships, plastic surgery fellowship, minimally invasive, colorectal, things like that. And so I specifically went into a bariatric / minimally invasive fellowship.
Sure.
So it would be actually, it's a funny story. I actually started off my fellowship I matched to East Carolina University, which is going to be in Greenfield, North Carolina. And when I went there was a lot of complications, and the people that were training there had left the facility. So I actually had to restart my fellowship at Charlotte. So
Oh, wow.
very thankful that the staff at Charlotte Medical Center was willing to accept me as a fellow, and I restarted my fellowship there. But then I went to a specifically bariatric fellowship. So getting trained in doing Roux-en-Y gastric bypasses, sleeve gastrectomies, revisions, how to take care and treat bariatric patients is what I specifically went into.
Listen, I'm very glad you found somewhere else to go. And it sounds like you got there quickly and they were able to sort of restart it and pick up, you didn't lose much time, but.
No, but it's scary.
Yeah, absolutely.
My husband and I sold our house. We moved from Akron, Ohio to Greenfield, North Carolina, which we're like, we know nobody. And then we had to relocate to Charlotte. So it was a little bit of a turmoil time, but it was okay. It worked out in the end. So
yeah, and I'm sure they always say things work out for the best, and I'm sure that was the case in your situation because you got through it. But before we talk about where you've gone since your fellowship, which I do want to talk about, can I ask why you chose bariatric?
Yeah, I really enjoyed the surgery. So in residency, you kind of do rotations. So you rotate through the different services. And I really enjoyed the minimally invasive services. So I started off as a resident doing a lot of open cases, big up and down laparotomy incisions, traumas, dead gut, big open surgeries. And they were okay, but I just thought they were messy. They weren't really delicate or fine. And you just have to do it that way. And then when training progressed, and even some more of my, attendings that I was training with, they started doing things more laparoscopically, minimally invasive. It was really intrigued me. It's so delicate. It's so fine. You can do this complex surgery through a little hole that's about 2 centimeters. It's amazing.
It really is.
Yeah, and the recovery time is improved, healing time is improved, everything. It's just the impact on the patient is great. And so I really like laparoscopic surgery. And then I started working with one of my mentors in Akron, and he did a lot of bariatric surgery there. And it was just fascinating. The fact that we can manipulate someone's anatomy to get them to lose weight, improve their diabetes, improve their blood pressure, improve their cardiovascular risk factors. It was just astonishing. And so I really got interested in it. And when I did my research year and did all the background on it, looking at all the data that supports it, it just kind of solidified why I like bariatrics.
Yeah, and minimally invasive and just those approaches, it really does help improve patient outcomes.
And not only that, but you're not going to get, I mean, if most people will probably need more than one surgery in life, not just bariatric, but I'm just saying most people need their gallbladder out at some point in their life or something else comes up. You never know what you're going to need. If you have a minimally invasive surgery, the chances of you having a successful second surgery is pretty high. When you have a big open incision and a lot of complications that could come from that, it's harder to do your next surgery. It's possible, but the complication rates go up. So it's always nice to be able to start laparoscopic and continue laparoscopic.
Yeah. So you finish your fellowship, and then did you immediately move to where you are now?
So I did have a job before this in Las Vegas. So I took a private practice opportunity out in Las Vegas, Nevada.
Okay.
Primarily for bariatric surgery.
How long were you doing that?
I was doing it for about a year and a half.
Okay, and then you transitioned to where you are now in St. Louis?
Correct.
Okay, and where are you right now in St. Louis?
At DePaul, SSM Health DePaul Hospital.
Okay.
In St. Louis.
And you were, I'd imagine, brought on there to do bariatric and minimally invasive surgeries.
Correct.
And how long ago was that?
I just started here in May.
Oh, awesome. Well,
yeah,
congratulations on the new job and the move, I'd imagine.
Yeah, everyone's like, you came from Vegas, it's so nice out there, and I do miss the weather and the mountains, but I originally grew up in the Midwest around Chicago, and so I do miss the Midwest. I'm a Midwest person, so it's nice to be closer to home, closer to family.
I'm sure that's true. And listen, I've been to Vegas in the summer. It's not always awesome.
No, it is hot. It gets hot, yes.
So a lot of changes have come to the bariatric space over the past 20 years or so, and I was wondering how big of a change robotics has been. I've been fortunate enough to be able to use a simulation Da Vinci machine, and I was blown away by how a minute change can make a big impact on what you're doing inside the body.
It's funny because I'm trying to incorporate more of robotics into my practice. I didn't train robotically, but it is becoming, like I said, we started open, we did laparoscopic, now we're doing robot. It's a lot. It's easier. It's so ergonomic because right now I do everything. We think about it. They're on trocars. There's sticks going through a little instrument where you have kind of looks like scissor holders. So that's how I train now, and I can sew by myself. You know what I mean? You do everything that you can with a robot with these static tools. When you go to a robot where you're sitting, you're not standing. You have more dexterity. You have more movement. I actually think it's a lot easier. It gives you more flexibility. I think. But again, I'm coming from where I've done it laparoscopically to robotically. I think if you just start on your own, it just, it's like, how does a kid pick up a Game Boy and start playing? They just do. You know what I mean? And you take some time and you get better at it.
And being that you are sort of younger in your career, and this may be anecdotal because you haven't talked to every bariatric surgeon out there or maybe minimally invasive surgeon out there, but would you say that sort of the new guard of surgeons that I would say that you're a part of, are they quicker to adopt technologies like robotics than, say, the older set of surgeons that have been doing it for 20 or 30 years at this point?
I think so, but I see both sides. So I see there's like a middle ground that, if you're middle of your career, already happy with what you're doing, you kind of stay with what you know. If you're young, you want to do the innovations. You want to know what's out there. You want to see the new technology, the new tools. And then I also see some of the really older surgeons who probably, have more difficulty with some of the laparoscopic just due to dexterity, ergonomics, that are picking up robotics because it's actually more comfortable for the surgeon.
Well, like you said, and maybe this is just my own laziness coming through, but the fact that you'd be able to sit through the surgery instead of standing through the surgery, that seems very appealing to me. And I'm in my 30s, so I'd imagine a surgeon that's in their late 50s, early 60s, it would be
want to sit.
Yeah, I don't blame them for that. And is there like another fellowship that you do to learn robotics, or is that sort of at your own pace? Get in there and figure it out? Like, what are the continued education programs like for that type of new technology and new advancements?
So there are some fellowships that are robotic heavy. So if you know that you're definitely going to be putting it in your fellowship, and I guess I came at a time where the robot was still kind of, not, I wouldn't say voodoo, but still very
Sure.
new. You know what I mean? And you have to get people to train you on it. So there are some fellowships that are robot heavy, but they're far and few between, so you got to find
Right.
them. And so for me, I didn't get fellowship trained in robot, but you can do it throughout your residency and then just afterwards. So you just have to work with, the local rep actually from Intuitive, that for the Da Vinci, if you're using that
Sure.
system. And then there's modules that you train on. So it's kind of like using the robot, like you probably, when you saw it, there's a little like box that's attached to it that they simulate.
Yes.
It's like a simulator, and you practice on that first. And then once you are comfortable at that level and you do certain tasks that you need to do at a proficiency, then you go do a course where you do it on animal models. You can practice the animal models. And then once you feel comfortable with that, then you advance to incorporating into your practice. And then when you do that, you have a proctor that comes out and helps you with it at that time.
And then you sort of, I'd imagine there's some sort of certification process for, and maybe not just robotics, but any sort of new technique or technology that comes out.
Correct. They want to make sure you're proficient, you feel comfortable, and the reps from the companies are always around to help. The nice thing about the robot is there's nothing, it seems scary and it's the big, device that you're using, but I think it's gonna be so helpful for patients. It's the same thing you're doing. I think for me, you're away from the patient. I have that connection when I'm at the patient's bedside. I feel like, there's no disconnect when I'm at the robot console, which is 10 feet away from the patient. It's kind of like playing a video game. You see it on the monitor, but you don't really feel like you're there, so it's a little bit of a learning curve.
And that's actually an interesting point because, like you said, when you're standing next to the patient, you are more connected to them. And that's probably all, psychological. I mean, you're still doing the same sort of thing, probably the exact same way through a robot. You're just standing further away. That's an interesting line to draw there. I didn't think about that, especially with that video game connection. That's super interesting. So let me ask, being that obviously any surgeon, whether they've been in the game for 15 years or 5 years or 30 years, they're always going to be hearing about and looking to sort of new advancements or new things that are in the pipeline to sort of change the way surgeries are done. Are there any of those sort of advancements that you know about for the bariatric or minimally invasive space that you think will be coming in the next 3, 5, or 10 years?
Yeah, I really think there's there's more work being done on how we can manipulate from a surgery perspective. What else can we do? Like Roux-en-Y gastric bypass is a standard for bariatric surgery. We compare all the new procedures to that. There's different ways. How do we manipulate it? How can we do variants to that procedure that make it better? That's always kind of in the background that people are studying, and then there's other things, new technology. So, using endoscopic measures to do surgical things. So, for sicker patients who really can't tolerate surgery, reducing the size of someone's stomach by just using an endoscope, which is a camera that goes down their mouth, things like that. Those are coming out. I think they're around, but they're not very heavily used currently. So I think in the next couple of years, we'll really see more advancement in there.
So just for the listeners that don't quite know what bariatric surgery is, can you give a very brief sort of general explanation of what bariatric surgery focuses on?
Yeah. Well, in bariatric and metabolic, they're trying to, incorporate the word metabolic into bariatric surgery because it's not just about weight loss. It's all about improving metabolic, composition, metabolic outcomes. But so bariatric surgery is surgery that alters the anatomy of a patient in order to help them lose weight to improve their medical condition. So, the two most popular surgeries out there, probably a sleeve gastrectomy and a Roux-en-Y gastric bypass. Those are the two most common bariatric operations that help patients lose weight. So basically surgery to help lose weight is what bariatric surgery is.
Sure. Now, and I do want to qualify it by saying it's not for people who just want to lose 5 or 10 pounds.
Correct. Not at all.
Yeah, it's for people who, are, and maybe you can speak to this better than I can, at least more eloquently, but, who are sort of severely overweight. I'm sure there's a medical terminology for it, and that are not having success through other means, whether that is lowering their caloric intake and working out more. They're just not able to have the success. And that's leading to, things like diabetes or things like that. Is that sort of the people you focus on with your practice?
Correct. These people usually have over about 100 pounds of extra weight to lose. Typically, they do have a medical comorbidity, like you mentioned, like diabetes or high blood pressure, sleep apnea, reflux, things that are secondary to having extra weight. And so, yes. And then usually this is kind of not a last resort, but when people struggle with their weight, if someone's never tried to adjust their diet or exercise, then this isn't this isn't the first go around. It should be someone who's, had struggled with their weight, who's, tried lost weight and regained it. So not for someone who's like, oh, I need to lose 5 pounds because I had Thanksgiving, not
Right. Yeah.
Those patients wouldn't really qualify for bariatric surgery.
So if someone comes to you and they've never really tried to work out, and but they do have they're carrying 100 pounds of extra weight, like you said, they've never really tried to work out, and they've never really tried dieting and things like that. You just said that they're not maybe the best candidate for bariatric surgery. So how do you explain to them that what you offer is not for them?
It's hard because you never want to turn someone away that's really struggling with their weight.
Sure.
And I guess it comes out in, me talking to them and, really getting to know what their rationale is. Some patients come in and they're not ambulatory. They can't walk and they're not going to be able to exercise. So, if it's someone like that, or they're limited because of joint pain, they kind of have a good reason of why they haven't been doing
Sure,
it.
yeah.
And so it all depends. If someone comes in and they're just obviously non-compliant, then no, it's going to be a hard discussion and a hard realization that you're not going to be successful, because the bottom line is the surgery is just a tool. It's not going to do the work for you. So if you're not willing to exercise before, or at least trying to do behavior modification or lifestyle changes, you're not going to be successful. It's like having a car. If you don't change the oil, it's not going to work on you very well.
Right.
You have to do those things in your life. You have to make those lifestyle changes to be successful. So it's sometimes not a very pleasant conversation, but it's a real conversation you have to have, because I want my patients to be successful. Part of our, where I work at SSM Health, part of our program, it is a multidisciplinary program and an inclusive program. So we do have mental health providers and dietitians. And so in order for you to get surgery, you do have to, as a patient, you have to be cleared by the mental health provider and the dietitian to make sure that there's nothing that can be, optimized before you go to surgery.
Sure. And I'd imagine, and you mentioned this while you were explaining that just now, but I'd imagine that bedside manner is very, very important with issues like this. And maybe this is my projection, so forgive me if that's the case, and please correct me if that's the case. But a lot of people's ego or maybe self-image is tied up in what they weigh. So I'd imagine that that's a very difficult conversation to have with someone.
It is. Again, every patient's a little different. Some people, come in because they know and they've been struggling, so they're willing to discuss that.
Sure.
Some people are referred by a primary care doctor and they don't even know why they're there. So that's always a hard conversation. But it's true. You have to be sensitive about these issues, especially, it's hard. There's a lot more than just what you eat and if you exercise that is involved in obesity. And obesity is a legitimate disease. It's how people, process their sugar, how they process their food. It's genetic. There's so many factors. So just, looking at someone and just, boiling it down to, oh, you eat too much. That's not right. And so you have to be sensitive to that.
Yeah. So if you don't mind, I'd like to shift gears here for just a moment and talk to you about, you are the first female surgeon that we've talked to.
Okay.
I like to close with a similar question every time, because a lot of our listenership is, people who work in the field currently or who are considering going into the field. Mm-hmm. But it seems like there are fewer female surgeons than there are male surgeons. So what advice would you give to a woman who is looking to go into surgery?
What I would say is, and even in the medical profession, if someone is interested in surgery and that's their passion and they enjoy it, what I would say is, don't let all the other stuff around medicine dishearten you. There's a lot of other things. There's always going to be, ups and downs at any kind of job or any kind of position. Whenever you're trying to get through a program or school, or there's always going to be ups and downs. Right. So I think if someone was really interested in it and they enjoy it, you're going to enjoy it in life. Just you have to kind of put your head down, get yourself through it, do what's best for you. And then when you're said and done and you go through all the residency and the fellowship and the training, when you can just, kind of tailor your career, you will be happy and you'll be satisfied with your work. I think if you like what you do, it's a lot easier to deal on a day-to-day basis with work in general. And so I would say that especially for female surgeons, you're right. I mean, there's a lot of, I think the entering class for med school is about 51% female and 49% male. So there's more women now going to med school, but in surgery, you're right, it's still very skewed. There's not as many women. I think it's just because family planning takes part in that, long training
Yeah.
that always takes control. So what I would say is for women, if you're interested, don't let, the length scare you. But make sure you take time for yourself. You have just, even if it's a little bit, focus on what's important in your life and in your career. And you have to kind of do the best of both. You know, there's no perfect person. You know what I mean? You
Yeah.
do the best you can, and you really need to rely on your support structure, your support system. I have a great family and I have a great husband. My husband helps me out with a lot of things, just as I'm sure as many of my male colleagues, they have a spouse that probably helps them out with a lot of their stuff.
Sure. Yeah.
And so I'm fortunate that I have that. And if someone is single, and unmarried going through it, it is a little harder, but you kind of lean on people in your life that can help you out, and I think that's important to have that support structure in your family, in your life.
Yeah, and I think no matter what gender you are, it's going to be difficult either way. It's not an easy thing to undertake or finish. So having a support structure, I'd imagine, is very important either way.
Yeah, it's critical. And you gotta learn to say no. I mean, that's the hardest part, especially being a woman. I know I hate saying, when people ask you for favors or come, especially family, oh, come to this, come to that. And you have to just learn to say no. I need my own time.
Yeah.
And, they're your family, they will understand. But it did make my life a lot easier when I was able to kind of excuse myself from, all the social events. You miss it, you do miss out on things in life. That's definitely, kind of a sacrifice you make when you become a physician or a surgeon. You do sacrifice some things, but, from where I'm at, again, I'm younger in my career, but I'm very happy where I am right now. So, I would just say, if it's important, just see if, put your head down, do your work and see if you can get through it. When I think back, I still remember my first day of med school and thinking, oh my God, this is never going to end. And I still remember my first day of residency being like, God, another 6 years, and now I'm out of it for 3-4 years now, and I can't believe it's gone,
Yeah, no, I completely understand. I do think the importance of learning how to say no is very, very important in any aspect of life. But I can definitely understand how when you got to buckle down and really, really study, which you do. I mean, I imagine surgeons or really just anyone in the medical field when it comes to that stuff, because it's such a high risk profession, especially surgery. You've really got to know your stuff, right? So you've really got to focus and hunker down. And I think those that love you and will support you and the people you surround yourself with will understand that.
Correct. And I think that's important.
Yeah.
I think that can make or break, your success. Because if you're not, if you don't have a support group, I mean, you're on your own. And, we don't live on an island. We need help. Everybody needs help once in a while in their life.
Absolutely. No one gets anywhere alone, you might say.
Nope.
Yeah.
Correct.
Absolutely.
Correct.
Well, thank you so much for being on the podcast. We really appreciate your time.
Yeah, I appreciate it. Thank you very much.